Okay, let's talk about child and adolescent psychiatry. This chapter covers the assessment and management of problems with mood, anxiety, or conduct in children and young people. Neurodevelopmental disorders, including intellectual disability, can cause similar symptoms or be comorbid with these disorders, but are covered separately in the previous chapter and chapter 18. Okay. Mental illnesses that commonly affect adults, such as eating disorders, bipolar affective disorder, and schizophrenia, can also present in adolescents. These are predominantly covered in their own chapters, but also briefly here. Finally, this chapter briefly covers child abuse. Mental disorders in children can both be caused by child abuse and increase the risk of experiencing abuse, and it is important to always be alert to this possibility. Child and adolescent mental health services. And of course, here we are talking about the British guidelines and the British services. Child and adolescent mental health services provide emotional and mental health support, diagnosis, and treatment to individuals up to the age of 18 years. Children often find it difficult to explicitly verbalize psychological distress. Instead, the presenting problems is most commonly a non-specific concern about a child's abnormal behavior or performance, like being disruptive in the classroom. This often raised by someone other than the young person, like parents, school teacher, or pediatrician. This means the ability to make a good history and synthesize information from multiple sources is particularly important in CAMHS, which is Child and Adolescent Mental Health Services. Family and wider community are important in assessing and maintaining a young person's well-being, and this is reflected in the broad composition of multidisciplinary team in CAMHS, CAMHS, which are likely to include psychiatrists, psychologists, occupational therapists, community mental health workers, social workers, community psychiatric nurses, family therapists, and creative therapists. Here we have a figure that shows an overview of the uh, tiered approach to CAMHS service common in the UK. Okay, we have tier 1, 2, 3, 4. This is the surface, so this is the structure of it. We have in tier 1 universal service, then mental health practitioners, then specialist CAMHS, then highly specialist CAMHS. About universal services, we are talking about GPs, social workers, health visitors, school nurses, teachers, youth justice workers, and voluntary agencies. In Tier 2, we are talking about mental health practitioners like CAMHS trained, manage young people with milder disorders, provide training to universal services. In Tier 3, we are talking about specialist CAMHS. We have here MDT providing assessment and treatment in community, manage young people with more complex and severe disorders. Highly specialist CAMHS provide intensive support to the most severely affected young people like inpatient unit, day programs, sexual trauma team, and pediatric liaison team. Okay, should know that. Let's talk about attachment. Attachment refers to the bond between an infant and their primary caregiver. How the primary caregiver respond to a young child's needs during their early years sets the tone for that child's expectations for the rest of their life, how others are likely to behave toward them, and how they should behave in return. Put simply, if a child is shown kindness and understanding, they are likely to become a kind and empathic adult. If a child is ignored and neglected, they are less likely to be social or caring toward others. If a child is treated inconsistently, sometimes with love, sometimes with disdain, they will expect the world to be unpredictable and chaotic. People in authority to be untrustworthy and themselves as unable to be in control. So, disrupted attachment during early childhood can often lead to behavioral difficulties in children and potentially personality disorders in adulthood. Importantly, not everyone who has a difficult upbringing will have a difficult adulthood. Many individuals are resilient, and behavior and thinking patterns can be changed, sometimes with help of psychological therapy. It is also important to note that primary caregivers do not always provide an optimal early environment for a range of reasons. Some within and some out with their control. For example, postnatal depression, substance use, poverty, bereavement, war. Okay. Nonetheless, encouraging parents and care providers to provide a loving and responsive environment for infants and young children has become a key governmental priority. Again, encouraging parents and care providers to provide a loving and responsive environment for an infant and young children has become a key governmental priority. Hints and tips. As you meet children, young people, and adults who seem to be behaving in harmful ways, it can often be helpful to try to understand how their early experiences have shaped them. Often, thoughts or behaviors that are helpful during times of adversity, for example, not trusting others when experiencing abuse, can become unhelpful in other times and contexts, like difficulty forming close relationships. About epidemiology, mental health problems affect around 1 in 10 children. Here we have the table that is talking about this for each disorder. Okay, but before that, let's talk more about attachment styles. We were talking about attachment, so we have what's called secure attachment and insecure attachment. Insecure attachment has 3 types: avoidant insecure attachment, ambivalent or resistant insecure attachment, and disorganized insecure attachment. In secure attachment, which represent 2/3 of children, the caregiver behavior would be responsive, understanding, and consistent, while the child behavior would be happiness and curiosity. Adult attachment style would be autonomous. Adult behavior would be able to self-soothe, but also able to maintain relationships. While avoidant insecure patients, the caregiver behavior is aloof, unresponsive, and ridiculing. The child behavior would be emotionally distant and withdrawn. The adult attachment style is dismissive. The adult behavior, we mean by adult behavior, the child when became adult. That's it. When becomes adult. Okay. Desire to be independent, avoidance of intimacy. Ambivalent, insecure attachment. The caregiver behavior would be at times sensitive, at times ignores. That would make the child anxious, uncertain, and angry. The adult attachment style would be preoccupied with that, and the adult behavior, the adult would be hypersensitive to rejection and care seeking. Disorganized, insecure attachment. Caregiver behavior as abusive, scary, or scared. Child behavior sad, angry, and fearful. Adult attachment style disorganized. Adult behavior fearful, abuse, and dissociative. Now let's talk about epidemiology of mental disorders in childhood and adolescence. Intellectual disability. The typical age of presentation is infancy or preschool. The prevalence in under 18-year-olds post-typical age of onset is 3%. Autism spectrum disorder, the same typical age, preschool or primary. No, it's not the same. It's preschool or primary, 1%. ADHD, preschool or primary, 5%. Anxiety disorders, primary or older, 5%, up to 20% have a phobia. Conduct disorder, primary or older, 8% in males and 4% in females. ODD, oppositional defiant disorder, primary or older, 4%. Eating disorders in adolescents, 1%. Depression in adolescents, 4%. Bipolar affective disorder, late adolescence, it is rare. Schizophrenia also is rare in late adolescence. Personality disorders, the age of onset is usually late adolescence. Characteristic traits common but not usually diagnosed in adolescence usually. Okay, so that's it. Let's talk about mental illness in children and adolescents. Let's start with anxiety disorders. The anxiety disorders in childhood are often thought to be exaggerations of normal developmental trends rather than discrete illnesses in themselves. They rarely persist into adulthood and tend to have a good prognosis. The treatment of these disorders is focused on behavioral and family therapy. In late adolescence, common anxiety disorders of adulthood, like generalized anxiety disorder, panic disorder, and obsessive-compulsive disorder, emerge. Diagnosis and management are very similar to adulthood, but with an even stronger emphasis on psychological therapy. What about separation anxiety disorder? Normal separation anxiety usually occurs in children from 6 months to 2 years of age. However, some children experience inappropriate and excessive anxiety about separation from attachment figures. This disorder is only diagnosed when the anxiety is of such a severity that it is markedly different from other children of a similar age, or when it persists beyond the usual age period. For example, a 6-year-old girl becoming incredibly distressing when her mother drops her off at school. Phobic anxiety disorder. Minor phobic symptoms are common in childhood, and the object of the phobia varies with developmental stage. For example, fear of animals or monsters in preschool children. Phobic anxiety disorder is diagnosed when the phobic object is age appropriate. A 9-year-old boy who is afraid of monsters under the bed, or where levels of anxiety are clinically abnormal. So again, when the phobic object is age inappropriate here. Inappropriate, okay. Or where levels of anxiety are clinically abnormal. Non-developmental phobias like agoraphobia do not fall under this category, but under the adult phobia category. Obsessive-compulsive disorder. Median age of onset is 10 years, but can be from age 5. About 2/3 of young children have various ritual habits, like lining up toys, specific stories before bed, that parents may be concerned is OCD. What is important to bear in mind is the developmental stage of the child. Rituals, habits help children to make sense of the world around them as they grow and develop. OCD is suggestive if the ritual or habits is very intense or frequent, impairs the child's ability to function, or causes them distress. Another key difference between diagnosis in adults and children is that children are not required to recognize their thoughts as abnormal. And actually, it's not there even for adults in DSM-5. Treatment is largely psychological. Social anxiety disorder. Normal stranger anxiety occurs in well-adjusted children from 8 months to 1 year of age. Social anxiety disorder is a persistent and recurrent fear and/or avoidance of strangers. This disorder is only diagnosed when the anxiety is of such a severity that it is marked different from other children of a similar age, or when it persists beyond the usual age period. Hints and tips. Social anxiety is common in children with neurodevelopmental disorders. Remember, screen for autism and attention deficit hyperactivity disorder in children in a child presenting with anxiety. Another hints and tips. School refusal is the refusal to go to school because of anxiety. It may be caused by separation anxiety in younger children, another mental illness like depression, social phobia, or negative psychological factors like bullying or teasing. Truancy, by contrast, is an absence from school by choice and is associated with conduct disorder, poor academic performance, family history of antisocial behavior, and large family size. Okay, we are done with anxiety disorders. Let's talk about disorders of social behavior. Conduct disorder. Conduct disorder is one of the commonest reasons for referral to CAMHS. Okay. The disorder is characterized by a repetitive and persistent pattern of aggression to people and animals, destruction of property, including fire-setting, deceitfulness or theft, and major violations of age-appropriate societal expectations or rules, like truancy, staying out at night, running away from home. Rates among populations in young offenders institutions have been estimated to be as high as 87%. Okay. The male-to-female ratio is approximately 2 to 1. Etiological factors include genetics, parental psychopathology, like mental illness, substance abuse, antisocial personality traits, child abuse and neglect, poor socioeconomic status, and poor educational attainment. Many adolescents improve by adulthood. However, a substantial proportion go on to develop antisocial personality disorder and substance-related problems, especially those with an early age of onset. Management is predominantly psychosocial. The National Institute of Health and Care Excellence, NICE, 2013, the National Institute for Health and Care Excellence recommends parental skills training, programs for parents, carers, cognitive behavioral therapy. So we have this, parental skills training, cognitive behavioral problem solving programs for young people, and multi-modal interventions, multi-systemic therapy, aiming to influence how the young person interact with their family, school, community, and criminal justice system. Input from social work is often required as the young person can be out with parental control. ODD, Oppositional Defiant Disorder. A persistent pattern of negative, defiant, hostile, and disruptive behavior in the absence of behavior that violates the law, or the basic rights of others, as occurs in conduct disorder, like theft, cruelty, bullying, or assault. Children with this disorder deliberately defy requests or rules, are angry and resentful, and annoy others on purpose. Management is very similar to conduct disorder. Hints and tips. It helps to remember that family histories should relate to both genetic lineage and factors that influence psychological development. The risk for developing conduct disorder is increased if a first-degree relative suffers from it, but also if there is a history of antisocial personality disorder in a close family member, regardless of whether they are a biological relative. Reactive attachment disorder. Reactive attachment disorder occurs in children under 5 years of age who have been severely neglected and unable to form a secure attachment to a primary caregiver. Manifests with abnormal social relationships, for example, fearfulness and hypervigilance, withdrawal, listlessness, aggression, I think this is restlessness, I don't know, not seeking or responding to comfort, no interest in play. Paradoxically, some children may be indiscriminately warm and disinhibited towards strangers, showing no preference for their primary caregiver. In DSM-5, the last sentence here is related to another disorder. So we have reactive attachment disorder, which is something like, fearfulness and so on, isolation, withdrawal, and so on. But disinhibition is another disorder. It's called something disinhibited disorder. Okay, disinhibition social engagement disorder. Yeah, disinhibited social engagement disorder. Elective mutism or selective mutism. Elective mutism is a selectivity in vocal communication depending on the social circumstances. The child speaks normally in some situations, for example at home, but is mute in others, for example at school. These children have adequately developed language comprehension and ability, although a minority may have slight speech delay or articulation problems. It usually presents before the age of 5 years, is slightly more common in girls, and is associated with psychological stress, social anxiety, and oppositional behavior. Okay, we are done talking about disorders of social behavior. Let's talk about disorders of elimination. Non-organic enuresis. This condition is characterized by the involuntary voiding of urine in children who, according to their developmental stage, should have established consistent bladder control. Therefore, ordinarily not diagnosed before the age of 5 years. Okay. It may occur during the day or night and is not directly caused by any medical condition like seizures, diabetes, or urinary tract infection, or even constipation, structural abnormalities of the urinary and structural abnormalities of the urinary tract, or use of substance like diuretics. 2 types of enuresis have been described. Primary enuresis means that urinary continence has never been established, and secondary enuresis means that continence has been achieved in the past. Non-organic enuresis occurs in around 7% of 5-year-olds, 4% of 10-year-olds, and around 1% of adolescents over 15 years. Gender disruption is equal in younger patients. However, cases that persist into adolescence tend to be males. Etiological factors include genetics, developmental delays, psychosocial stressors like moving house, birth of a sibling, start or change of school, divorce or bereavement, and inadequate toilet training. About 75% of children with non-organic enuresis have a first-degree biological relative who has had the same problem. Management, according to NICE guidelines 2010, involves exclusion of physical cause. Parental education about toilet training, especially in primary enuresis. Behavioral therapy like pad and buzzer apparatus, star chart, and bladder training. And as a last resort, pharmacotherapy like imipramine and nasal desmopressin. Most cases of non-organic enuresis resolve by adolescence. Most cases of non-organic enuresis resolve by adolescence. Okay. What about encoparesis or encoparesis? Non-organic encoparesis. This condition is characterized by the deposition of normal feces, not diarrhea, in inappropriate places in children who, according to their developmental stage, should have established consistent bowel control. Therefore, ordinarily not diagnosed before the age of 4 years. It may be due to unsuccessful toilet training where bowel control has never been achieved, primary encoparesis, or occur after a period of normal bowel control. This is secondary encoparesis. Encoparesis may result from a developmental delay, coercive or punitive potty training, emotional, physical or sexual abuse, disrupted parent-child relationship, parental marital conflict, or can feature as a symptom of a neurodevelopmental disorder like autism or intellectual disability. About 1 of 5-year-olds have the condition, and it is more common in males. Management include ruling out an organic cause like constipation with overflow incontinence or anal fissure or gastrointestinal infection, assessing and training disrupted family dynamics, ruling out child abuse, parental guidance regarding toilet training and behavior therapy like star chart. Stool softeners may be used for constipation. The prognosis is good with 90% of cases improving within a year. This is good. Okay, we are done talking about elimination disorder. Let's talk about disorders arising in adolescence and adulthood, like eating disorders. Eating disorders, we've talked about these in chapter 16 and 24, often commence in adolescence. Symptomatology and diagnosis are the same as in adulthood. The management is very similar to that recommended for adults, except the first-line treatment is always psychological therapy. Usually, family-based therapy is the gold standard in young people. Not medication. When assessing physical risk from eating disorder in adolescents, it is important to refer to age-specific guidelines. For example, the Junior Management of Really Sick Patients with Anorexia Nervosa guidelines. Okay. Depression. Depression also arises frequently in adolescents. The treatment is similar to adults, but psychological therapies are first line, and a far smaller range of antidepressants are recommended. NICE Guidelines 2005 suggest watchful waiting for mild depression and an individual psychological treatment, cognitive behavioral therapy, family therapy, or psychodynamic psychotherapy for moderate to severe depression. This can be combined with fluoxetine from the start or fluoxetine trial if no improvement is seen with psychological therapy. Second-line antidepressants are sertraline and citalopram. Red flag. Selective serotonin reuptake inhibitors should be started at lower doses in adolescents than adults. Young people should be monitored closely for thoughts or self-harm or suicide weekly for the first month, or commencing treatment or after a dose increase. Okay. Bipolar affective disorder and schizophrenia. Severe and enduring mental illnesses such as bipolar affective disorder and schizophrenia often begin to manifest in adolescence. 60% of bipolar disorder has onset before age 20. but are uncommonly fully symptomatic or diagnosed until late adolescence. Suspected cases are generally managed in early intervention for psychosis teams. Classification is the same as in adulthood. Treatment follows the same principles as in adults, but focuses on psychological treatments and family interventions rather than pharmacological treatments, with a smaller range of medications used in young people. Management of acute mania remains pharmacological, of course. Personality disorder. The concept of diagnosing personality disorder in CAMHS is somewhat controversial. By definition, personality disorders are stable and enduring patterns of maladaptive behavior. Young people are still developing their way of responding to the world and have had limited life experience, making it hard to predict whether any maladaptive behavior will persist or not. However, core aspects of personality are evident from infancy onwards, and it is to be expected that someone who will later have a personality disorder will show evidence of these traits from childhood onwards. Certainly, adolescents exhibit characteristic behaviors and symptoms identical to those seen in adults with personality disorders. It can be harmful to label a young person with a personality disorder diagnosis, which turns out to be incorrect, but it can also be harmful to misattribute problems due to personality traits to a different mental disorder, or to minimize them. Pragmatically, if a diagnosis is helpful, like in young person or carer understanding to assess appropriate treatment, to avoid inappropriate treatment, or to assess other supports, it is useful to make treatment of it's useful to make. So again, if a diagnosis is helpful, it is useful to make. So you can weigh that. Treatment of personality disorder in CAMHS is very similar to that in adulthood. Psychological therapies in CAMHS offer a particularly powerful opportunity to allow the young person to adjust their trajectory. Child abuse. Child abuse includes the overlapping concepts of physical, sexual, and emotional mistreatment, as well as neglect or deprivation of the child. Child abuse is very common. Around 1 in 4 adults report severe abuse of some kind as a child, with 1 in 20 children in the UK experiencing sexual abuse. This is very much. Table 30.3 lists the risk factors associated with child abuse. Let's talk about them. Here we have some risk factors for child abuse. We have parent, environmental factors, we have child factors. Parent or environmental factors, like parents who were abused. They are more likely to abuse their children. Parental substance abuse. Parental mental illness, like intellectual disability, depression, schizophrenia, personality disorders, and step-parent. Young immature parents. Parental criminality. Poor socioeconomic status and overcrowding. All of these are risk factors for abusing a child. We have some child factors like low birth weight or premature children, early maternal separation, unwanted child, intellectual or physical disability, challenging behavior, hyperactivity, and excessive crying. Okay. In addition to the physical manifestations, victims of abuse may present with failure to thrive and symptoms of depression, anxiety, aggression, age-inappropriate sexual behavior, and self-harm. They are also at an increased risk for the development of substantial range of psychiatric problems in later life. All National Health Services, all National Health Service trusts in the UK have specific child protection guidelines, which should be easily accessible and consulted before they are needed. Um, Next, we will talk about a book that provides some general principles. All healthcare staff, not just child psychiatrists and pediatricians, have a duty to protect children from harm, and the safety of a child should always take priority. If a child discloses abuse of any sort, or if you suspect that they are being abused or neglected, confidentiality cannot be maintained, and this should, if appropriate, be explained to the child. Comprehensive notes should be kept, and care taken to allow the child to make the disclosure in their own words without suggestion from others, either family or healthcare staff. Okay. Concerns should be reported as soon as practically possible. While local procedures vary slightly, the police, social workers, and the duty pediatrician should be able to offer guidance. In some cases, the child may be in imminent danger, like being taken home by the alleged perpetrator. It may be necessary to involve the police or prevent further harm, and to remove the child to a place of safety. Okay, here we have a red flag. Children have the same right to confidentiality as adults. However, if you believe or suspect a child is being abused, you have a duty to break confidentiality and report this promptly to authorities, as per local guidelines, generally a social worker or a pediatrician. If there is imminent risk, you should contact the police. Another red flag. What to do if a child discloses abuse to you? First, listen. Then say, then share. Listen carefully. Do not interrupt or express surprise or your own views. Say, you have done the right thing to tell me. It's not your fault. I believe you. Share. Tell a senior doctor. Share the information with the authorities. Consider if the child is safe to go home. Tell the child what you plan to do if age appropriate. Document carefully using child's own words. Do not change the alleged abuser. Assessment considerations in young people. Where's the... Okay. Where's the table? Okay, I think this is books 30.7. Where is that? I cannot find it. Anyways, assessment considerations in young people. Problems need to be considered in the context of child's developmental stage. For example, temper tantrums are normal for a 2-year-old child, but should have subsided by age 5 years. Parents or carers usually accompanying children and young adolescents. It is often useful to first interview them, with or without the child present, to obtain a full description of the current concerns as well as a complete history, psychiatric, neurodevelopmental, educational, and medical. An indirect evaluation of the parents' personalities, marital relationship, and style of parenting often creates another perspective from which to understand the context of the presenting complaint. An interview with the young person usually follows. The ability of youngster to provide a candid account of their difficulties varies dramatically. The assessment style should be tailored to the individual abilities of the young person rather than to their age. In children who are unable to articulate their inner experiences, usually younger children, it is often necessary to observe them in play situations. The child's own understanding of their difficulties should, if possible, be taken into consideration, as this can affect their management in terms of motivation to engage with psychosocial interventions and concordance with medication. It may be helpful to change the order of assessment to build rapport. For example, start with open and general questions about school and home rather than the presenting complaint. The importance of obtaining collateral information cannot be overstated. This is extremely important in fully understanding the development of the presenting problem and the young person's premorbid functioning. It includes obtaining academic, educational, or psychological reports, as well as discussions with teachers and any other agencies involved. Remember to obtain consent from the parent or carer and the child if they are able. Further information can be obtained from structured and semi-structured interviews, like K, SAD, SP, diagnostic interview schedule for children, objective assessment instruments like autism diagnostic observation schedule, and parent-teacher self-rating skills like strength and difficulties questionnaires and attention deficit hyperactivity rating scales. Anyways, so here we are reaching the chapter summary. Mental health problems are common in children and adolescents. Collateral histories and multidisciplinary working are particularly important in children and adolescent mental health services. Anxiety disorders in childhood often resolve by adulthood. First-line treatment of mental health problems in young people is generally psychological, not pharmacological. Child abuse is common. Communicating concerns is key. So that's it. هذا والله تعالى أعلم وصلى الله وسلم على سيدنا محمد وعلى آله وصحبه أجمعين.